Also, friends, I would like to share with you the case that I presented for my IAACD accreditation exam part 2. It was quite well appreciated, and I've tried to incorporate those 10 points that we discussed for good case documentation and presentation. Do have a look at it and give me your feedback. Thank you. So this is a case that I had presented for my IAACD accreditation part 2 exam, wherein I have spoken about the smile enhancement with direct composite bonding. So a 23-year-old male patient came to our clinic with a chief complaint of presence of gaps between his teeth, and also he was unhappy with the shape of his front teeth. He said he's getting married in about a month's time, and his desire was to improve the overall appearance of his smile. So in the first appointment, we collected all the data and the information that will aid us in the proper treatment plan. It includes communication with the patient, taking photographs, videos, impressions for study models. Oral prophylaxis and scaling and polishing was done for the patient. And before even we did that, we recorded the shade using the Vita shade guide and the composite button technique. So when we communicated with the patient was interviewed and careful pointers were made of his expectations and desires related to a new smile. Patient seemed to be camera conscious. It was noted while making the preoperative video. He desired larger teeth filling up the gaps. And due to time and economical constraints, he requested for a minimalistic treatment. Then we started taking the photographs. Remember, consent has been taken from this patient, and patient in fact was very happy, and he wanted to share about him. So he has even allowed me not to hide his identity. So when we took the photographs, these are the extraoral photographs from the front and from the right and the left side. These are smile views from the front and from the right lateral and left lateral. These are the intraoral photographs, wherein we can see this is a right lateral view in the closed position, the right lateral view in the teeth parted position. Similarly, on the left side, and this is the MIP view, and this is with the teeth parted. The center one, which is a main picture, it is called as the anterior aesthetic view, which shows the teeth from canine to canine. Here, a video was taken of the patient, wherein when the patient speaks the words, we observe how much is the incisal visibility. Next, we made impressions and study models out of it. The shade was recorded using the composite button technique and also using the Vita shade guide. Now, once we have collected all the records, we sat and we did the complete aesthetic analysis for the patient, which includes the facial analysis, dentolabel analysis, smile line analysis, gingival analysis, and teeth analysis. Let's see them one by one. So the facial analysis includes checking the facial proportions, the facial midline, the interpupillary line, the commissural line, and the dental midline. You can see the dental midline was not coinciding, although the proportions were quite uniform. There was parallelism between the interpupillary line and the commissural line. When the patient was speaking, we could see that the amount of the visibility of the incisal edges of the teeth. With the lips parted while slight smiling and talking, the maxillocental incisor exposure was about 2 mm approximately. The dentolabel analysis, it showed medium lip line, which means that when the patient smiled, mostly teeth were displayed and only a part of the gingiva was displayed when he was smiling. The smile line analysis showed slight discrepancy because of pronounced mesial angulation of the incisors. The smile line was not ideal. The gingival analysis showed these kind of blunted papilla because of the gaps or the diastemas that he had. Also, there was a dark interdental triangle visible. This was the main area of interest, canine to canine of the upper arch, where we observed the central incisors were divergent. They were mesially inclined. The incisal edges were not straight. They were oblique. Relatively small and narrow lateral incisors bilaterally. The maxillary right canine was mesially rotated. giving a huge gap. There was a huge space between maxillofacial incisor and the canine, which is about 4 to 4.5 millimeters. The space between the left side lateral incisor and canine was about 1.5 to 2 millimeters. So after complete analysis, we gave these treatment options to the patient. The first option was orthodontic treatment. Secondly, we gave him the option of no prep composite restorations. And thirdly, we gave him the option of minimally invasive ceramic veneers. The approximate time, the cost, and the pros and cons of these treatment options were mentioned to the patient. Patient refused the orthodontic treatment due to time constraints. On the study models, we got a laboratory wax-up done. So when the patient came to us in the second appointment, we went ahead and did what is called as the aesthetic try-in or the aesthetic test drive for the patient, which involves the first step as transfer of the mock-up to the mouth by using the silicone putty index and bisacral composite. The photograph was taken at 12 o'clock position to evaluate the position of the incisal edges. So photographs were taken with the APT, which is a aesthetic pre-evaluative temporary, to evaluate the smile preview. And the photographs and was shown to the patient, and also the how it looked was shown to the relative. And then we discussed with the patient. Patient's opinion regarding the smile preview, that he found maxillary sentinel incisors longer than he desired, and he showed interest only in closing the lateral spaces. So in the smile preview, he found the sentinel incisors to be very long, and he desired to close the gaps only between the lateral and the canine. He did not want us to do any treatment for his sentinel incisors. After detailed discussion with the patient and taking into consideration patient's age, desires, existing intraoral condition, the following treatment plan was devised. So final treatment plan involved direct composite restorations on the maxillary right and left lateral incisors and canines for closure of the spaces, that is diastemas, and also to improve the shape and the anatomy. For the sentinel incisors, as patient refused to do any kind of restoration, we just did some aesthetic contouring of the distal incisal edges to make them straight, look straight. So third appointment was the one wherein we did the actual treatment, starting with administration of local anesthesia, isolation with rubber dam was done. As it is no prep composite restoration, we just need to use the coarse disc to roughen the surface in order to remove the aprismatic enamel. The procedure starts with etching with 37% phosphoric acid. You can see the rest of the teeth are protected with the Teflon tape. It was rinsed and washed, followed by drying and application of 5th generation bonding agent. Then with the help of the silicone putty index that we had, we made a palatal shell using A3 enamel shade on the putty index and adapting it on the tooth. The increments of body shade A3 and the enamel shade A3 were used to complete the built up of the maxillary left lateral incisor. The final layer was cured under glycerine to remove the oxygen inhibited layer. Similar protocol was used for the maxillary left canine. Exactly same protocol was followed for the right side lateral incisor and canine. So immediately after we were done with the build-ups and we removed the rubber dam, this was a grossly how it looked. You can see after removal of the rubber dam, there are these bleeding spots here and there. The teeth look a bit dehydrated. We used pencil marks to mark the transition line angles and to give it a good anatomy, primary anatomy. After doing the gross finishing polishing, and this was how it looked. Then we did the aesthetic contouring of the sentinel incisors to make the incisal edges look straight and removed all the occlusal interferences. This is how it looked immediate post-operatively. This is a smile view right lateral, big difference, which is a remarkable difference really, that made the patient really happy because such a huge diastema of about 4.5 millimeters got closed just with direct composite bonding, no prep. On the left lateral, it is slightly visible. The difference is slight visible, as in like it's not remarkable, but definitely the space has been closed. So these are the retracted right and left lateral views, standardized images. Although from the front, the difference was not much visible. This is the front view, pre-op and post-op. This is the right lateral view, pre-operative and post-operative. You can see a big difference. And also this is the full face left lateral view, pre-op and post-operative picture. And this was a post-operative video. Although the video is not that clear, but yeah, he said he was quite happy, and a happy patient really makes us happy. Thank you.